Good morning, my name is Monica. Today I am going to present a detailed discussion on ventilator-associated pneumonia caused by pseudomonas aeruginosa. This topic is important in microbiology because pseudomonas aeruginosa is one of the most common and dangerous pathogens responsible for hospital-acquired infection, especially in intensive care units. First is introduction. A ventilator-associated pneumonia, commonly known as VAP, is a type of hospital-acquired pneumonia that develops 48 hours or more after a patient has been placed on mechanical ventilation through an endotracheal tube. Patients admitted to the ICU are highly susceptible because mechanical ventilation bypasses the body's natural defense mechanism. Among the various microorganisms responsible for VAP, Pseudomonas aeruginosa is particularly significant because of its ability to survive in hospital environment from biofilm producer toxins and develop resistance to multiple antibiotics. The mortality rates associated with Pseudomonas VAP can be very high, especially when treatment is delayed or antibiotic resistance is present. Microbiological characteristics of Pseudomonas aeruginosa: gram-negative Bacillus aerobic bacterium, non-spore forming, Oridas positive, non-lactose fermenting bacterium. It belongs to the family Pseudomonas. One important feature of this organism is its ability to produce pigments such as first cyanin, a blue-green pigment that gives colony their characterized color. Yeah, Bavardine, a yellow-green fluorescent pigment that helps the bacteria acquire iron from the environment. The bacteria also produce a characterized fruity or grapes-like odor, which is often observed in microbiology laboratory. Receiver and transmitter. Pseudomonas aeruginosa is widely distributed in nature and can survive in most moist environments. Common receivers include water system, humidifier, ventilator tubing, respiratory equipment, sinks, catheter. Transmission usually occurs through contained medical device or aspiration of contaminated secretion into the lower respiratory tract. Pathogenesis of ventilation-associated pneumonia. The pathogenesis of VAP causes by Pseudomonas aeruginosa involves several complex steps. Step 1. Colonization. For the organism first colonizes the upper respiratory tract, including oropharynx, nasopharynx, and endotracheal tube surface. Patients in ICUs often receive broad spectrum antibiotics which distribute normal flora and allow Pseudomonas to colonize more easily. Step 2. Biofilm formation. One of the most important virulence mechanisms is biofilm formation. A biofilm is a community of bacteria enclosed within a protective extracellular matrix. On the surface of endotracheal tubes, Pseudomonas produce alginate, forming a thick biofilm that protects bacteria from antibiotic, preventing cell attack, allows persistent infection. Because of a biofilm formation, bacteria can survive for long periods despite treatment. Step 3. Microaspiration. Secretion containing bacteria leak around the endotracheal tube cuff and enter the lower airways. This process is called microaspiration and is considered the main mechanism responsible for VAP. Step 4. Pulmonary infection. The bacteria multiply within the alveoli and trigger an intense inflammatory response. Neurotrophils migrate to the infection site, releasing inflammatory mediators that damage lung tissue and impair gas exchange. Virulence factor. The, the severity of infection is due to multiple virulence factors. First is exotoxin A. Exotoxin A inhibits protein synthesis by interactive elongation factor 2. This leads to cell death, tissue necrosis, excessive lungs damage. Second is elastin. Elastin regarded elastin, fiber, collagen, immunoglobulin. As a result, lung tissue and blood vessels become damaged. Third is phospholipid C. This enzyme destroys cell membrane and contribute to tissue destruction. Fourth is cyclocynin. Cyclocynin generates reactive oxygen specific. These are radicals damage epithelial cells, reduce cellular movement, impair mucosal clearance. 5 is flaring and pili. This structure helps bacteria adhere to respiratory epithelial cells and facilitate colonization. 6 is alginate capsule. This alginate layer protects the bacteria from phagocytosis and promote biofilm formation. Host immune response. When pseudomonas enter the lungs, alveolar microphages recognize bacterial components such as the lipophilicus. This stimulates the release of inflammatory cytokines including tumor necrosis factor alpha, interleukin 1, interleukin 6, interleukin 8. This medicator recruit neutrophils to the lungs. Although neutrophils help eliminate bacteria, excessive inflammation causes alveolar damage, pulmonary edema, reduce oxygen changes. This contributes significantly to respiratory failure. Clinical manifestation. Patients with pseudomonas were typically present with first respiratory symptoms. Increased pulmonary symptoms, dyspnea, tachypnea, increased oxygen requirement. Second is systemic symptoms, fever, chills, malaise, tachycardia. Third is laboratory finding, leukocytosis elevated, C reactive protein increased, fluorocycline levels. Fourth is radiological findings, chest X-ray often show new infrastructure, costodilation, patchy obstruction. Laboratory diagnosis. First is microscopy. Gram staining of respiratory secretion shows numerous neutrophils, gram-negative rods. Culture. Samples may include endotracheal aspirator, bronchoalveolar level fluid protector, specimen brush samples on culture media. Blood agar. Large colonies with beta hemolysis. And Meconium agar, non-lactose female colonized. Biochemical test, oxidase positive, catalyze positive. Molecular method, PCR can rapidly identify bacterial DNA and resist genesis. Treatment. Imperial therapy usually include anti-pseudomonas antibodies such as cefepime, ceftazidime, marofan, imperial. Several cases may require combination therapy with aminoglycosis, fluoroglycemide. Prevention. Strict hand hygiene, daily assessment for exuberant oral care with chloroquine, proper ventilator maintenance. Okay, thank you.